Did you know that 80% of adults with mental illness first experience symptoms during childhood or adolescence? Yet 2/3 of these young people never receive the mental health services they need?
Really? That's quite staggering. I mean, we often think of adult mental health as something that develops later, but that early onset and such a huge treatment gap, that's a silent crisis.
Exactly. And it's not just about individuals suffering. The implications ripple out to families, schools, communities, and society at large. The economic and social costs are profound.
So what do you think are the main reasons so many kids and teens with disabling mental illnesses go unnoticed or untreated?
Well, it's a complex mix. Developmental factors, systemic barriers, social stigma, and diagnostic challenges all play a role. Today, we're unpacking that complexity, focusing on the epidemiology, risk factors, assessment hurdles, and especially the critical role nurses play in intervention.
Right, and for our listeners with clinical backgrounds, we'll dive into the nuances, from neurodevelopmental changes to cultural considerations and therapeutic modalities. By the end, I hope we'll all have a deeper understanding of how to better support this vulnerable population.
So, starting with the scale of the problem, about 1 in 5 Canadian children and adolescents suffer from a major mental illness that significantly impairs their functioning at home, school, with peers, and in the community.
Yeah, and at any given time, roughly 13% of youth are experiencing a mental health disorder. But here's the kicker. 2/3 of these young people aren't receiving the services they need.
That treatment gap is huge. And it's not just numbers. Suicide is the second leading cause of death among youth aged 10 to 19 in Canada, with suffocation being the predominant method.
That's heartbreaking. And the disparities are even more alarming for Indigenous youth, who face suicide rates 5 to 6 times higher than non-Indigenous youth.
Right, and that reflects systemic inequities, lack of protective supports, limited access to culturally appropriate care, and social determinants like poverty and marginalization.
I also noticed that suicide rates among female youth are increasing, while rates among males are decreasing. That's an interesting trend that definitely needs more exploration.
Absolutely. It challenges some of our assumptions and points to the need for gender-sensitive approaches in prevention and intervention.
The Mental Health Commission of Canada's 2012 strategy, Changing Directions, Changing Lives, was a turning point in recognizing youth mental health as a priority. But despite that, barriers like fragmented services, long wait times, unclear screening protocols, and provider shortages persist.
And those barriers contribute to delayed or missed diagnoses. Which brings us to the developmental and diagnostic challenges unique to this population.
Right. Childhood and adolescence are periods of rapid physical, neurological, cognitive, and emotional development. That makes diagnosing mental health disorders particularly tricky.
Especially in younger children who have limited language skills and emotional insight. Symptoms can be subtle or expressed differently than in adults.
Plus, clinicians and parents often hesitate to intervene early, waiting to see if symptoms are just developmental lags or trauma responses that might self-correct.
But the brain is changing so fast during these years. Synaptic pruning, myelination, prefrontal cortex maturation, all influencing emotional regulation and behavior. So symptoms can fluctuate quite a bit.
That developmental complexity demands nuanced assessment tools and approaches tailored to the child's age and cognitive level.
Exactly. And that's where nurses come in, using developmental screening tests and observational techniques adapted to each child.
Speaking of complexity, the etiology of mental illness in youth is really a multifactorial puzzle.
Yes, it's a dynamic interplay of genetic, neurobiological, psychosocial, environmental, and cultural factors.
For example, genetic predispositions exist for disorders like autism spectrum disorder, bipolar disorder, schizophrenia, and ADHD. But resilience and environment modulate whether these vulnerabilities manifest.
Neurobiological changes also play a role. Neurotransmitter imbalances involving serotonin, dopamine, and norepinephrine are linked to mood, anxiety, and behavioral disorders.
And temperament, the innate style of emotional and behavioral response, interacts with parental temperament and caregiving quality, influencing attachment and risk.
Environmental stressors like abuse, neglect, exposure to violence, poverty, and gang involvement significantly increase risk.
I was struck by the statistic that about 30% of Canadians report physical or sexual abuse before age 15. Males are more often physically abused. Females more often sexually abused, though male sexual abuse is underreported due to stigma.
Witnessing violence is also traumatizing, leading to PTSD symptoms, aggression, academic failure, and social difficulties.
And indigenous youth gang involvement is often linked to poverty and social marginalization, compounding mental health risks.
Cultural factors matter too. Minority status, discrimination, and lack of culturally appropriate services affect help seeking and symptom expression.
LGBTQ2 youth face particularly high rates of bullying, violence, and discrimination, which increase suicidality and mental health problems.
Nurses must be culturally competent and advocate for inclusive, affirming care environments to address these disparities.
That's a critical point. Now, shifting to the nursing role. Nurses are often frontline in identifying, assessing, and intervening in youth mental health, especially bridging gaps in fragmented systems.
Assessment includes gathering developmental history, conducting mental status exams, suicide risk assessments, and observing child-caregiver interactions.
Tools like the Denver 2 Developmental Screening Test and the Youth Risk Behavior Survey help quantify developmental and behavioral concerns.
And communication must be tailored to developmental level. For younger children, play therapy or storytelling can facilitate expression and assessment.
Suicide risk assessment is especially crucial. Past attempts are the strongest predictor, but nurses also explore plans, lethality, mood, impulsivity, and social context.
Family dynamics, school functioning, and comorbidities like ADHD or conduct disorders are also assessed to get a full picture.
Ethical complexities arise around consent, assent, and dissent in minors. Nurses must respect autonomy while navigating legal frameworks.
Right, and including children in decision-making supports their growth even if they can't legally consent.
Moving on to therapeutic modalities. Treatment is multimodal and family-centered, often combining psychotherapy, behavioral interventions, pharmacology, and community supports.
Family therapy focuses on improving family functioning, communication, and parenting skills. Multiple family therapy offers peer learning and support.
Group therapy varies by age, play-based for young children, skills and discussion-based for adolescents.
Behavioral therapy uses operant conditioning principles, with point or level systems rewarding adaptive behaviors. The principle of least restrictive intervention guides use of restraints or seclusion.
Cognitive behavioral therapy is evidence-based for mood and anxiety disorders, focusing on restructuring negative thought patterns.
Milieu management structures therapeutic environments in inpatient or residential settings to promote safety, growth, and social learning.
Mind-body therapies like yoga, for example, the Be Bold program and guided imagery, have shown benefits in reducing anxiety, improving attention, and decreasing substance use in adolescents.
Play therapy and therapeutic games facilitate expression and coping in children with limited verbal skills.
Bibliotherapy and therapeutic drawing provide alternative expressive outlets and insight into emotional states.
Pharmacological treatment is cautious and adjunctive, given limited safety data in youth. Stimulants for ADHD, SSRIs for anxiety and depression, and antipsychotics for severe behavioral symptoms are common.
Nurses educate families on medication management and monitor for side effects, which is vital given the vulnerability of this population.
Now, neurodevelopmental disorders. These affect brain function, leading to impairments in language, learning, motor skills, and social interaction.
Autism spectrum disorder affects about 1 in 66 children, with core symptoms of social communication deficits and restricted, repetitive behaviors.
Diagnosis is often delayed until school age, which is unfortunate because early intervention is critical, but access is limited and costly.
ADHD is characterized by inattention, hyperactivity, and impulsivity, often comorbid with oppositional defiant disorder or conduct disorder.
For diagnosis, symptoms must be present in multiple settings, like home and school. Treatment includes stimulants like methylphenidate and behavioral interventions.
Specific learning disorders, such as dyslexia and dyscalculia, affect academic achievement and require accommodations.
Motor disorders like Tourette's involve tics and are often comorbid with OCD or ADHD. Behavioral therapy is first-line treatment.
Nurses assess developmental milestones, parent-child relationships, and risk for abuse in these populations.
Disruptive, impulse control, and conduct disorders are another major category.
Oppositional defiant disorder involves recurrent, hostile, defiant behavior toward authority without seriously violating others' rights.
Conduct disorder is more severe, with persistent antisocial behavior, aggression, and disregard for societal norms.
Childhood onset conduct disorder is associated with poor peer relationships, aggression, and risk for adult antisocial personality disorder.
Adolescent onset conduct disorder often involves peer-related misconduct, substance use, and risk-taking.
Bullying is a common manifestation, with victims experiencing low self-esteem, depression, and suicidal ideation. Bullies themselves are at risk for substance misuse and antisocial behavior.
Assessment includes family dynamics, cognitive and moral development, school history, and justice system involvement.
Treatment is challenging. Intensive community-based programs like multisystemic therapy show promise.
Pharmacological options have limited efficacy. CBT and family therapy remain mainstays.
Nurses support families in behavior management, safety planning, and accessing resources.
Anxiety disorders are the most prevalent mental health disorders in children and adolescents.
Separation anxiety disorder involves excessive fear of separation from caregivers, often triggered by stressors like loss or trauma.
Generalized anxiety disorder features excessive worry about routine activities, with physical symptoms like headaches and sleep disturbance.
Assessment includes family relationships, developmental level, coping styles, and symptom severity.
Nursing interventions focus on preventing panic, supporting regression, boosting self-esteem, and teaching coping skills like deep breathing and positive self-talk.
CBT and pharmacotherapy, including SSRIs and anxiolytics, are effective treatments.
School refusal is a common manifestation. Gradual reintegration with support is key.
Mood disorders, PTSD, and other conditions also affect youth.
Major depressive disorder and bipolar disorder present with symptoms similar to adults, but often with irritability and somatic complaints.
Risk factors include abuse, family discord, chronic illness, and social conflicts.
PTSD in children may manifest as repetitive play, reenacting trauma, nightmares, and anxiety. Comorbid depression and self-harm are common.
Feeding and eating disorders like pica and rumination disorder occur in childhood. Interventions focus on safety and family support.
Systemic challenges remain, especially the transition to adult services.
Youth transitioning out of child and adolescent mental health services at age 18 face significant discontinuity of care.
Research shows youth feel unprepared, uninformed, and terrified by the arbitrary age cutoff, with unclear roles and responsibilities in transition planning.
Continuity of care and individualized, co-designed transition plans reduce distress and improve outcomes.
Nurses play a critical role in advocacy, education, and coordination during this vulnerable period.
Ethical and cultural considerations are also paramount.
Respecting children's rights to participate in healthcare decisions through consent, assent, and dissent is ethically complex but essential.
Cultural competence is vital to avoid misdiagnosis and to provide respectful, individualized care.
Nurses must be aware of their own biases and the socio-cultural context of patients and families.
Special attention is needed for marginalized groups, including Indigenous youth and LGBTQ2 adolescents, who face disproportionate mental health challenges and discrimination.
So to wrap up, early identification and intervention are critical to prevent chronicity and improve lifelong outcomes.
Multimodal, family-centered approaches are most effective.
Nurses are pivotal in assessment, therapeutic intervention, education, advocacy, and care coordination.
Addressing stigma through contact-based education and community engagement is essential.
And systemic improvements are needed to reduce barriers, improve access, and ensure continuity of care, especially during transitions.
Ongoing research and funding are crucial to develop and sustain effective programs.
It's a complex landscape, but with informed, compassionate care and systemic commitment, we can make a real difference for children and adolescents facing mental health challenges.